Hi, and welcome to Physio Tribe. My name is Dhuliawala, and I'm a neurological physiotherapist working at PhysioFunction. Treating patients with neurological condition has increased my special interest in treating patients with traumatic brain injuries and spinal injuries. And the most common cause of a spinal cord injury is the traumatic spinal cord injuries, which can occur due to motor vehicle collision or bike accidents or falls or even gunshot stabs and some sports injuries. Now, yesterday in the part 1 video, we talked about subjective assessment and the importance of doing a comprehensive subjective assessment. And today we're going to talk about objective assessment and how important that is to be able to manage your patients with spinal cord injury. So once you've done the comprehensive subjective assessment, it is necessary that you verify the information gathered from subjective assessment in your objective assessment. Now, when I do my objective assessment, I look at the following points. So the first one I check with the patient is their sensation. Now, depending on the level of injury, when whatever I've got in my subjective assessment, I start thinking about what levels I am thinking the patient might have loss of sensation at. So already that is going in my mind. I will check with my dermatome levels as well, and I will confirm that with my objective assessment. So once you have checked all the sensations, your pinprick, your pressure sensation, your touch sensation, your temperature sensation, even if you've got vibrating fork, you can try that as well, and check patient's sensation, and make sure at each level you check all the sensations. After that comes your checking patient's tone. So you can check patient's tone, check the spasticity, also make sure you check all the involuntary movements if the patient have. Now again, this depends on patient's level, whether patient is complete or incomplete injury. Now, in involuntary movements, you might want to check patient's clonus, if they have any clonus in their feet or in their arms, because you can then create your management accordingly. Also check if the patient has any spasms and how are the spasms, when do the spasm come. So, and also when the patient is, when you're doing further transfers, you look for all these involuntary movement, not just during this period. Next, I will be looking at the range of motion, and you check for active and passive range of motions. You also look into patient strength, and then you can confirm that with the myotome levels. So again, you need to know what level patient is at, and you can confirm that with your assessment. So next one we're going to talk about is now this bowel and bladder assessment. It's not really an assessment, but something you need to ask your patient about their bowel and bladder routine and how they manage their bowel and bladder. Now, some of the patients who have complete spinal injury, they might be taking some suppositories, or they might be for the bowel movements, and some people might be constipated. So you just need to ask patient that, and also about their bladder, because if the patient is self-catheterizing, you need to make sure the patient's timing are not getting hindered by the therapy sessions. And also some patients with complete spinal cord injury might, if they self-catheterize themselves and they don't do it quick enough, some people might have problems with infections or problems with some bladder problems. So this will again impact your management, because if patient has too many infections, this will cause hindrance or stoppage in your therapy. So you need to make sure you address that and also educate the patient or refer the patients eventually in your management. The next one is respiratory assessment. Again, depending on the level of injury, if the patient is quadriplegic or the patient has high level lesion, they might be more prone for respiratory complications. So you need to evaluate what is patient's breathing pattern, what is their vital capacity, and Another important thing is you need to make sure how is patient's cough. If the patient can cough, that is a really great thing. That kind of reduces the following respiratory complications. But that's not it. You need to teach patients breathing exercises. So it's important to assess that respiratory problems, and so that you can address that in your management later. Coming into activity of daily living. Now, again, I work in community setup, and when patients come to us after the acute phase of rehabilitation, they have started to look into some of the activities of daily living already. For example, rolling in the bed, getting in and out of the bed, or sitting on the edge of the bed, or even dressing themselves, undressing themselves, looking into other personal activities, even some domestic tasks. So they might have worked with the occupational therapist, but still I like to explore what the patient can do, and if the patient has any ongoing goals from there, we need to look into that and we need to work into that if that is a priority for patients. And also you can work alongside your occupational therapist colleagues, and you can that's the way of working in a multidisciplinary team. Then one of the important part as a physiotherapist, I feel, is the mobility. And here you again check patients, you check patient sitting balance depending on the level of injury, and even complete or incomplete. You need to check and see what realistically patient can achieve. Then you look into whether, if the patient is incomplete, whether patient can stand. If the patient can stand, can they take a step forward? If the patient can take a step forward, can they walk? Do they need any equipment? And if they need any equipment, can they grip? Can they take weight on their forearms? So that you can decide the equipments accordingly. And then if the patient can walk, how much they can walk. If the patient can, needs minimal assistance, whether do they have foot drop, or do they, how is that hip and knee movements. So all these things you start looking at in your mobility and gait sections. Also, you look into patients transfers. So you have already looked at patients bed mobility, but then you look at patients, whether can the patient transfer from bed to the from the wheelchair to the plinth, where you're going to assess the patients, and how the patient is going to do that. If that's a complete injury patient, whether can they use a banana board, or can they just slide across, do a pivot transfer, or is there any other way the patient has learned, or do you need to teach patient that? Once the patient has transferred, you also look into how the patient can transfer from their wheelchair to another chair or a commode or their toilet, or even look at patient doing other type of split transfers, like if can the patient do can the patient get from their wheelchair onto the floor or onto a step. Because I normally like to teach my patients, if that is one of their goal, or I like to explore that side of teaching patients split level transfers from floor to the wheelchair and back again, just because young patients, when they have kids, they like to play with the kids on the floor, or even if the patient has sometimes falls, they need to be able to get back into the chair. So this gives them that level of independence and that level of achievability. So the next and last section I look at is the community wheelchair skills. Patients with incomplete spinal cord injury, or even some or complete spinal cord injury, or some incomplete spinal cord injuries, will have self-propelling wheelchair. Now, most of the patients have active wheelchairs, which is quite light to transfer, and the patients will be wheeling themselves in those wheelchairs. And you need to look at, can the patients mobilize themselves independently in their home environment, as well as how they're in the community setup. Can they go on and off a curb? Can they go on and off a gradient? Can they hold something like a cup of tea or a glass of water and wheel themselves around? And also, can they how good are they? How is their endurance while they are doing these wheelchair skills? So you need to first ask them and then assess if appropriate to the patient. Now, once you have finished your objective assessment, a detailed objective assessment, you look into doing some outcome measures with the patient. Now, there are lots of outcome measures available out there for patients with spinal cord injury. However, I tend to divide my outcome measures into patient-reported outcome measures and clinician-reported outcome measures. So in patient-reported outcome measures, they are more subjective and more of a questionnaire type outcome measures. So the first thing I would ask my patient is, if my patient has any pain, I would like to do VS scale on them. Now this is a very simple outcome measure, and if I am running short of time, or probably if I want to record something on a regular daily basis without frustrating the patient, this is something I would do, and I have done this in the past. I would give patient a scale of 0 to 10 and ask them to identify their pain on that scale, and I might do them at every visit when they come. And this is not just limited to pain, but this can be limited to, sometimes patients might have frustration of doing certain activity, and you can measure that level of frustration, because that will show you how easy it is getting over time and how patients are progressing eventually. So VS can be used for many things like spasms, or doing some activity in particular and taking patient's point of view. But also you can then do a clinician's reported outcome measure, so you have got data from patient in a subjective way, but also you're measuring that more in an objective way as well. So sometimes it works quite well. Another thing you can do is, if the patient's spasms are quite high, you can do the pen spasm frequency scale. Also, I have done skim with some patients, many of my patients actually, and it's a scale where you measure patients on their self-care, mobility, and many other things. So you can use that as well with your patients. I've also done a wheelchair user shoulder pain index, and sometimes when patients are using that wheelchair quite a lot, they might end up with shoulder problems or some kind of impingement. So again, pain is one of the problem, and this identifies pain doing those wheelchair tasks. Other things I have done is spasticity related quality of life measure, because some of my patients have got a lot of spasms and spasticity, and this is a good way of measuring that and recording it. So the clinician reported outcome measures are more of your objective outcome measures. The first one, when you're doing your objective assessment, when you're assessing your tone, you can do the modified Ashworth scale to measure the spasticity for the patients. For many incomplete spinal cord injury patients, you can use your standard neurological scales, but work balance is something else you can use as well, and I have used that with my patients. You can also use function reach test, where you get patients to stand and get them to reach forward and just measure that test. That gives you a bit of information on patients' balance, static balance in a standing position. Also, you can get patients to do dynamic gait index and HIMAT. Now, HIMAT is a very dynamic outcome measure, where you get patients to do things like hopping, backward walking, running, etc. And some patients at higher who are very high level, who are walking and have got incomplete spinal cord injury, this might be a very good outcome measure to do. And then you've got another standard outcome measures like 10-meter walk test or 5 times sit to stand test. Now, these are not just the outcome measures. There are plenty of outcome measures out there for patients with spinal cord injury, and there are some specific ones for quadriplegic patients, some specific one for wheelchair mobility. So you can pick up outcome measures which you really want for your patients. And if you want more information on outcome measures, generic outcome measures, or some specific pain outcome measures, or patient specific outcome measures, you can always leave your comments here or give us your feedback, and I will be more than happy to give you more information on that. So I really hope you enjoyed this part of the video on objective assessment. If you've got any comments, please make sure you list them below, and make sure you subscribe to our YouTube channel, and hit the button like at the bottom, and also you follow us on Twitter, Facebook, and Instagram. Thank you very much.